Hello and welcome to this lesson, Diabetic Retinopathy. So, diabetic retinopathy is a microvascular complication of diabetes mellitus, and this is one of the leading causes of blindness in the population, especially in the United States. This is a progressive damage to the retina due to prolonged hyperglycemia, and detecting it at the earliest stages is very important, and interventions can be crucial because it can prevent blindness in a very large group of people. So the first description of diabetic retinopathy, first comprehensive description, was done by Edward Jaeger. He was an Austrian ophthalmologist in mid-19th century. And we have several famous people that suffered from diabetic retinopathy. The first one is Mary Tyler Moore. She was an actress, and actually, he advocated for diabetes awareness because she was struggling with type 1 diabetes and faced many complications of diabetes, including diabetic retinopathy in the life. Another famous people who suffered from diabetic retinopathy is Steve Wonder. He's a musician and singer, and actually he became blind in one eye since childhood and developed diabetic retinopathy later due to diabetes. So now let's talk about pathophysiology of diabetic retinopathy. So note that all the changes that you are going to see in diabetic retinopathy is due to chronic hyperglycemia, and there are a couple of changes that you have to know for your board examination. Number one is the vascular change, and here we have endothelial dysfunction, basement membrane thickening, and loss of pericytes in the retinal capillaries due to high blood glucose. So breakdown of the blood-retinal barrier leads to the leakage of the plasma component into the vitreous humor. So another point is that the patient might have microvascular occlusion. So we have capillary closure. This causes a reduction in the retinal perfusion, and this leads to hypoxia. So hypoxia triggers inflammation and release of vascular endothelial growth factor, and this causes neovascularization, formation of new vessels in the eye. So another point, another part of pathophysiology behind the diabetic retinopathy is inflammation. As we talked, this is mostly due to hypoxia. Here we have a release of TNF alpha and IL-6 interleukin 6, which are pro-inflammatory cytokines, and these are further damaging the vascular integrity in the retina. And also here we have oxidative stress, and most of the oxidative stress is due to advanced glycation end products. These are worsening the oxidative stress. So what are the advanced glycation end products? These are family of compounds that are produced non-enzymatically. These are reactions that causes reducing the sugar, proteins, lipids, and nucleic acid, and they cause oxidative stress. So here you can see the changes and the difference between a normal capillary and a capillary that is damaged due to diabetic retinopathy. So as you can see in the normal cells, we have very good tight junctions, we have thin endothelial cells, and pericytes are intact. So in case of diabetic retinopathy, you are going to lose tight junction, and we have disruption of the tight junctions. We have endothelial cell hypertrophy. This causes narrowing of the lumen in the capillaries, and also we can have loss of pericytes, which further damages the blood vessels. Another point that you have to know for the board examination about diabetic retinopathy is the stages of diabetic retinopathy. So we have three stages that you have to know. Number one is non-proliferative diabetic retinopathy, or NPDR. So in this stage we have several changes. The first change is microaneurysm. So these are very small aneurysm, and this is the earliest visible sign that you can see in the fundoscopic examination. So the second change is retinal hemorrhage. So retinal hemorrhage or dot and blot hemorrhages are resulting from ruptured microaneurysm. When we have aneurysm, we have a weakened wall of the capillary, so as the result they can bleed and we have retinal hemorrhages. We can also have hard exudates, and these are lipids that are deposited from the leaky capillary. We can have cotton wool spots, and these are retinal nerve fibers that have infarction due to ischemia happening in the previous stages. Also, we can have venous changes, and here we have venous beading and looping, and again these two last changes are due to localized ischemia. The second stage is proliferative diabetic retinopathy. So before this stage, we are not producing new blood vessels. Here in this stage, we are producing new blood vessels. So as a result, we have neovascularization. This is due to release of vascular endothelial growth factor. So the new blood vessels are fragile, and as the result they can bleed. So these new blood vessels are forming on the retina and optic disc. So as the result of new weak blood vessels, we have bleeding into the vitreous cavity, and this can cause vision loss. Another change in this stage in the proliferative diabetic retinopathy is tractional retinal detachment. So here we have fibrovascular proliferation. This causes retinal traction, and as the result the patient may have retinal detachment, and this is one of the very serious complications of proliferative diabetic retinopathy. So the second stage, which can occur at any stage, is diabetic macular edema. So here we have, first of all, we can have edema. This edema can happen in any part of retina. So we can have diffuse or focal retinal thickening. This is due to fluid accumulation, and this can cause central vision loss. So now let's talk about presentation of the patient who is suffering from diabetic retinopathy. So in the earlier stages, the patient is going to be asymptomatic, and the findings that you are and the description of the disease will be only through the fundoscopic examination. But when we have an advanced disease, when we have either non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, the patient may have blurry vision or difficulty focusing. The patient may see dark spot in the visual field, or what we call floaters. Sudden vision loss can happen due to vitreous hemorrhage or retinal detachment, and also patient may have visual distortion, and this is usually due to macular edema. So here in this picture, you can see the difference between a normal eye vision and a patient who is suffering from diabetic retinopathy on the right side. So as you can see on the right side, the patient has floaters, the patient has a very hazy vision, and also the patient has problem focusing on the object because of diabetic retinopathy. Now, what are the diagnostic tools that we can use for diagnosis of diabetic retinopathy? First of all, we have fundoscopic examination, and this is essential for detection of microvascular changes like microaneurysm. Usually we are going to do dilated fundoscopy examination, and this better visualizes the fundus of the eye. Another test that we can use is optical coherence tomography, or OCT, and this is usually detecting the macular edema and retinal thickening. Another test that we can do is fluorescein angiography, and this is usually for detection of microaneurysms or neovascularization, and it is also capable of detecting ischemic areas in the eye. Fundoscopic photography is very essential for documentation and monitoring the progression of the disease. So these are the four tests that we are using for diagnosis of diabetic retinopathy, but the most important test that you are going to do in the clinic is fundoscopic examination, and this is very essential for establishing diagnosis of diabetic retinopathy. Now, what are the treatment options? First of all, note that the patient who is suffering from diabetic retinopathy should have very tight glycemic control. So hemoglobin A1C should be kept under 7%, and this is very essential. Also, high blood pressure is quite toxic because we have vascular weakening in the eye. So the patient should bring the blood pressure under 140/90 millimeter of mercury. Lipid control is very important for controlling hard exudate. So another treatment option here is focal or direct photocoagulation, and this is usually for sealing of microaneurysm and reduces the leakage of the blood to the vitreous humor and retina. And this is usually done for diabetic macular edema. Another treatment option that we have is pan-retinal photocoagulation, and this is done in order to reduce the neovascularization, and it is usually done in proliferative diabetic retinopathy. Another treatment option is anti-vascular endothelial growth factor therapy. So this is an intravitreal injection of some drugs that you are seeing on the on your monitor: ranibizumab, bevacizumab, or aflibercept. These are the first-line treatments for diabetic macular edema and proliferative diabetic retinopathy, and usually this slows down the progression of progressive diabetic retinopathy. Another option is corticosteroids. Again, we are injecting corticosteroid intravitreal, and this is usually done in diabetic macular edema, and this is usually done when anti-VEGF therapy is not effective. And the corticosteroid that we are using is usually dexamethasone. Pars plana vitrectomy is another option. This is a very invasive operation, and it removes the vitreous hemorrhage and treats the tractional retinal detachment. Thank you for watching.